Hello, everyone. Welcome to today's meetup. Today, we'll be talking about data science in mental health, opportunities, and advancements. And our speaker, Emily Halford, will be with us. She is a data analyst at New York State Psychiatric Institute. As the Magnimind Academy team, we are organizing a lot of events, meetups, workshops like these, and you're always welcome in our events. Having said that, I'm announcing Emily Halford for her speech. Thank you.
Okay, should I go ahead and start sharing?
Sure.
Okay. So, oops. Okay. So, hi, and thank you for having me. My name is Emily Halford, and I work in psychiatric epidemiology at the New York State Psychiatric Institute. I'm primarily focused on suicide prevention projects, and most of our research involves evaluation of the National Suicide Prevention Lifeline. So today, I'm going to be talking about the enormous potential role of data science in how we address mental health, both in terms of opportunities that are yet to be taken advantage of and encouraging advancements that have already been made. So first, I just want to give a quick overview of what I'll be covering in this presentation. So first, I'll give a high-level overview of data science and healthcare more generally. And then next, I'll talk about the current state of mental health field and the burden of mental illness and why this creates a need for a greater data science presence. I'll then cover 3 case studies representing encouraging advancements in mental health data science, and finally cover one of our projects in mental health data science at the New York State Psychiatric Institute. So I'm hoping to highlight the enormous potential for data science and mental health while keeping in mind that this area lags behind other areas in healthcare data science and that so much more work needs to be done. Okay, so starting out with healthcare data science in general. So there are a diverse array of data sources that are used in healthcare, some of which have been around for decades and some of which have only recently become available. So existing data sources include clinical trial data, which is extremely valuable for determining causality, but which can be limited by small sample sizes and lack of generalizability. There's also patient files and doctor's notes, as well as billing and claims data, all of which can give insight into diagnoses and healthcare usage. And then novel data sources include genomics data, which is becoming increasingly available, electronic medical record data, which enhances what we've been able to do with traditional patient files and doctor's notes, data from wearable and mobile devices such as Fitbits and various mobile apps. And there's also social media data and internet activity data, which have increasingly been used to assess a wide array of health problems. So admittedly, there is a blurry line between standard research and clinical trials and then data science, but regardless, data science and the use of new technologies in healthcare has definitely boomed. So even among existing data sources, a lot of this is more accessible now that everything is moving to computers and can be combined with novel sources to get even more insight out of these data. So what are some of the most common and high-profile use cases of data science in healthcare? So image recognition has worked astonishingly well for detecting a lot of health problems, most commonly malignancies and organ abnormalities. There's also been a big push forward in genomics research and moving towards precision medicine, so better targeting healthcare to the individual. NIH's 1000s Genome Project is a good example of this kind of work and focuses largely on things like heart disease and diabetes. There's also a big data science presence in hospital operations and the more business side of healthcare. And a lot of this takes the form of predictive analyses that look a lot like analyses done in other business settings, such as deciding when we need more of what type of staff to meet healthcare needs. So really what we're seeing is that there's been a lot of exciting advancements of data science in healthcare in general, but it's largely been focused on chronic diseases and hospital administration, and data science and mental health is lagging behind the rest of the field. So why does it matter that we're not seeing this growing data science presence as much in mental health? Largely that's because the burden of mental illness is astonishingly high. So SAMHSA and NAMI are 2 of the nation's most important mental health related agencies. And you can see here that the numbers that they found are very concerning. About 1 in 5 Americans has a mental illness, and those rates are even higher if you look at lifetime experience of mental illness. And the rates are also higher among young people, women, LGBT plus individuals. And then suicide is the second leading cause of death among 10 to 34-year-olds, which is very concerning. And unfortunately, so many people aren't getting care for these mental health problems. And in fact, only 43% of adults with a mental illness received treatment for it in 2018. So the average delay between symptom onset and treatment onset is a staggering 11 years, which just wouldn't be tolerated for so many other types of disease. And then to make it even worse, 40% of Americans live in a designated mental health shortage area, and then many health professionals don't participate in insurance plans. So many people find it cost prohibitive to get mental health care, even if they don't technically live in a mental health care shortage area. So I'm a really visual person, so I just wanted to look at some of those numbers quickly. As you can see, women are doing much worse in terms than men, and then younger individuals tend to have higher rates of mental illnesses as well. And we also see some racial differences, especially with higher rates among people who identify as 2 or more races. So then these are the same groups, but now for treatment rates. And so this chart is 2017 data. So the overall treatment rate is slightly different than the one I mentioned, but it's still not looking good. We can see that younger individuals were seeing much higher rates of mental illness, but are then actually doing the worst in terms of all the age groups in terms of treatment. And we also see that white people did not have the highest rate of mental illness, but they are having the highest rate of treatment, which is also problematic. And now we're looking at the designated mental health care shortage areas. So this darker blue here indicates that the whole county is a shortage area. The medium blue is that part of the county is a shortage area. And then the light blue is that none of the county is a shortage area. So we're basically just seeing there's a lot of the dark blue and not very much light blue. And to be fair, some of these lighter blue areas are very high population areas, such as New York. But really what's coming through is that there are just so many people who do not have access to the mental health professionals that they need. So we've established that mental illness is extremely common and that most people aren't getting treatment, but what are the impacts of that? So undiagnosed and untreated mental illness has serious consequences both for the individual and for their community. There's a strong relationship between mental and physical health, and the statistic that people with depression or a serious mental illness are at least 40% more likely to develop cardiovascular and metabolic diseases is just one that demonstrates that fact. So people with mental health problems are also more likely to drop out of school, to be unemployed, to experience homelessness, and to become incarcerated. So for so many reasons, it's just not okay that we're not properly addressing mental illness. Now, in many ways, mental health is actually a perfect application for data science. So data science can really do the most good in areas that aren't already well controlled, and mental health definitely fits that classification. We have these huge diagnostic and treatment gaps, and these represent complex problems that we don't understand well. And that kind of complex problem is really just so perfectly suited for data science, particularly for things like unsupervised learning that can look for connections and relationships on their own that we might have missed. And additionally, there's increasingly just so much data that we can work with to improve how we diagnose and manage mental health. And we really can and need to be taking advantage of these new capabilities. So I'd like to break the potential role of data science and mental health into 2 broad categories: understanding and then treating mental illness. So in terms of understanding mental illness, we can answer questions such as these. So, who is experiencing mental health problems? What signs and symptoms help us diagnose different mental illnesses? And how is all of this different in different populations? So data from wearable devices can be really useful to answer questions like this. And there's been some work using some that measure things like heart rate that have tried to identify anxiety attacks. Also, social media and internet activity data have come into play. For example, there's been some work looking at how you scroll through Facebook and Instagram and depression. And then doctor and therapist notes are also potentially very useful, especially as these get computerized. There's a lot of room for natural language processing and machine learning to identify potentially undiagnosed mental illness via these data, or to better understand patients who are already in therapy. And there's also a lot of potential for brain scans. This area lags behind other image recognition, in part due to the difficulties of getting large sample sizes. But we know that there's brain activity and changes associated with mental illness, so there's definitely potential here. So now in terms of treating mental illness, that second piece, data science can help us answer questions like whether or not a treatment works. And by formal, I mean something like a drug or kind of therapy. And then informal can be something like a calming app or exercise. And then any given treatment probably isn't going to work for everyone. So it's really important to identify who is likely to benefit and whose time we might be wasting by trying that treatment. And then finally, how do we identify people in need of treatment and find ways to get treatment to them? So the data science approaches that can help us answer these questions include traditional clinical trials that test a treatment against a control group, evaluations of these new, more accessible treatment options, such as apps and chat services. And then as chatbots and other similar AI develop, primarily through advances in natural language processing and predictive speech capabilities. These inexpensive and accessible treatment options may gradually become available more broadly. And finally, what I'm personally particularly excited about is the idea of mental health having a greater presence in the move towards precision medicine. Since so many patients wait all these years to even get treatment, and then when they do, spend even more years trying treatments that may even make them worse or don't work for them, if we could identify ways or things that are going to be more likely to work for that individual and shorten their time to getting care that's effective for them, that would just be so hugely beneficial. So to be fair, there definitely are challenges to taking these data science approaches to mental health, although I think that they are definitely surmountable challenges. So first of all, mental health problems have a level of attached stigma that just isn't there for the vast majority of other diseases. And this presents both a funding issue and a data issue, and that there often isn't the same level of money available or being raised for mental health issues, and then the relevant data is very sensitive. So people might feel much more comfortable knowing that data associated with something non-stigmatized, like an orthopedic issue, was being used than data from a suicide attempt or PTSD treatment. And additionally, social desirability bias, which is the tendency to answer in the way we think others want us to instead of truthfully, leads people to deny having symptoms or diagnoses that they do, which can create underreporting. So additionally, there's definitely room for improvement in our existing treatments and diagnostic capabilities. So data science can definitely help address these problems over time, but it is much easier to evaluate something that diagnoses a disease that we thoroughly understand. And for treatments, we don't have a clear biomarker or anything like that to look for to objectively tell us if it's working. And then circling back to stigma-related issues for a moment, it is absolutely essential that patient data representing these mental illnesses be kept private and confidential, which is definitely doable, but definitely also adds a bit of an added challenge. And then finally, the availability and quality of data representing mental health is gradually increasing, but there are still serious challenges here. So any healthcare data can be hard to acquire due to HIPAA laws. And in many cases, there's also really poor infrastructure for data collection and or data sharing. So many EMR systems don't communicate well with each other. And then some providers and therapists might not have anything computerized. And then only people who get formal diagnosis and treatment are represented in many data sources, such as clinical data. So since we know from before that only 40-something% of people were getting treatment for their mental illness, less than half the people you'd really want in your data set are represented in clinical data. And that's just really not representative of the whole population of individuals who are in need of care. So while I think it's important to be realistic and note these challenges, I still think that there's enormous potential for mental health in data science that will only expand as we get more and better data. So now I'm going to talk about 3 different case studies that I think represent the really exciting progress that's already been made in the field and which indicate how much more can be done. So the first is the crisis text line, which has used data science both to help us understand mental illness and to help us treat mental illness. They're getting at both sides there. So the crisis text line provides free crisis counseling by text by trained volunteers, and they're available 24/7. They've had over 5 million text conversations since starting out, and they really are a tech company at heart and emphasize the potential for data science to help them do their jobs better. So in general, the crisis text line is really great about responding to people in need quickly, but sometimes the number of people in need outnumbers the volunteers and people have to wait for a few minutes. So what they've done, which is really great, is to figure out a way to identify people who are at serious need and can't be kept waiting. And they've done this by using machine learning to identify words and emojis that indicate higher suicide risk and to bring these texters to the front of the queue. So in order to do this, they've analyzed data from text conversations that led to an active rescue, meaning that an individual couldn't stay safe or required some kind of emergency intervention. What they found isn't always intuitive, which really underscores the importance of making data-driven decisions instead of just relying on gut instinct. So they found that use of the words Advil and ibuprofen are 14 times more predictive of a suicide attempt than words like cut, die, suicide, and kill that you might expect to be more predictive, and that even the crying face emoji is 11 times more predictive than the word suicide. So we really aren't good at predicting suicidal behavior right now. There's no great screen that works particularly well or anything like that. So having data on text conversations that led to an active rescue allows machine learning to come in and find these insights that we really desperately need. And the crisis text line is also very conscious of how private the data that they have is, and texters can request that their data be wiped clean at any point. And then even if a texter doesn't do this, personal information like names, places, phone numbers, birthdays, and things like that is scrubbed automatically by a built-in algorithm. So that last example from Crisis Text Line was really about helping us to treat mental illness more effectively. But Crisis Text Line also uses their data to help us better understand mental health. So in addition to a blog that they regularly update with insights from their data, they also have a publicly available interactive dashboard that you can explore to learn about geographic and temporal differences in mental health problems and emotional distress. So I have a screen grab from that here. So this is the dashboard. You can see how many conversations that they've had. And then up top here, you have 2 geographic panels. And so you can see the default example is conversations about anxiety and stress. And so you can see that the Northeast is having a much higher concentration of those kind of conversations, as well as California. You can see the states ranked on the right side, as well as this overall map on the left. And then as you scroll down, you can see the most common co-occurring issues. So you can see that for conversations about anxiety, relationship issues, and depression and sadness are coming up very commonly at the same time. And then you can also see a time series plot, so how the conversations have changed since December of 2015. You can see that the number of anxiety and stress-related conversations has been pretty consistently going up, with an extra little blip around when COVID was really bad. And then you can see day of the week. So it looks like Tuesday is the worst day, and that weekends tend to be a little bit better for anxiety and stress, which makes sense. And then hour of the day, you're seeing that late night tends to be really bad, especially 10 p.m. That's the worst time. And then earlier in the morning seems to be a bit better for anxiety and stress. And then here you can select an issue. So we can just select anxiety again. And then you get in red a quote that was used in an actual text conversation about that topic, and then a word cloud of the words that are most commonly used to talk about your issues. So in this case, anxiety. And then up at the top, you can use the filters that they have to take this a bit farther and really interact with it more. So just for an example, I'm going to do substance abuse. And then in New York State, since that's where I live, you can apply that. And then whenever you do use these filters, it takes a few minutes to update that, just since there's so much data that is powering this dashboard. But it is great they have so much data to use. When you filter to one particular state, like I did for New York, the top 2 panels will stay the entire United States, just so you can get still these geographic differences. But then every panel below that will be filtered down to New York. So we can see that for substance abuse for the whole US, it's a very different pattern than anxiety and stress. It's much worse in more central states and northern states. But now for substance abuse filtered down to New York now, we're seeing pretty similar co-occurring issues as before, but now a very different pattern over time. And now it's much more stable. There's that same increase. Now weekends actually are worse. So Sunday is the worst day. We're seeing a very similar pattern for time of day, where 10 p.m. is quite bad again. And then you have to do this part manually, but you can do substance abuse again. And I see a new quote related to that topic, and then the words that were used to talk about that issue. Oops. Okay, so now this is Ellie, a 3D chatbot. And this next example is currently being used to diagnose mental illness, but has enormous potential for treatment down the road. So Ellie was created by University of Southern California's Institute for Creative Technologies and funded by the Defense Advanced Research Projects Agency to treat veterans suffering from PTSD. So she was developed by recording and then analyzing hours and hours of human mental health professionals to base her behavior off of. And Ellie serves the dual functions of being able to assist mental health professionals when they might be overburdened, and also hopefully allowing patients to be more open and honest than they might want to be with a real therapist. So since patients don't want to disclose information if they're afraid that they might be judged or identified, this kind of model is very useful. And that kind of fear about identification and stigma is especially true among veterans, given how much stronger the stigma is in that population, and also the potential employment repercussions attached to mental illness. So while patients are talking to Ellie, she observes 66 points on the patient's face and also makes note of the patient's rate of speech and how long they pause before answering questions. So this data collection has led to insights such as that patients with PTSD touch their head or hands more frequently than those without. And Ellie's creators really emphasize that right now she's a data gatherer, not a replacement therapist, but she really does provide so much value in collecting information that would be hard for a therapist or psychiatrist to get. And 2 studies really emphasize that fact. So the first, in Afghanistan, Ellie was found to identify more symptoms of PTSD than the standard post-deployment health assessment. And in the second, some participants were told that Ellie was controlled by a human who was watching their session, and these participants were less likely to open up than those who knew that Ellie was just a computer with no attached person. And that really emphasizes that technology like Ellie can get crucially important diagnostic information that might otherwise be missed. And also, although Ellie is not capable of being a replacement therapist right now, her success really provides a lot of encouragement that we might see similar technology reach the point that it could be a therapy alternative to help address provider shortages and those major treatment gaps that I was talking about earlier. So the third case study I want to talk about is Quartet Health, a mental health tech company based out of New York that is committed to improving mental health care. So they have a 4-part model to achieve this goal. The first step of that is identifying people who need care through provider referrals, patients signing up directly, including Medicaid patients, and screening for people who need care. And for this screening, they're using machine learning, and it's really where the data science comes in. So they're able to use patient medical histories and behavioral patterns to look for potential undiagnosed mental health problems. And one thing that they found to be indicative of anxiety, which I find really interesting, is that if a patient has repeatedly been tested for cardiac issues and had these come back negative, it's then more likely that they have an anxiety disorder. So the second part of their model is matching people to appropriate care, and they identify what treatment approach makes the most sense based upon the patient's indicated preferences, any clinical indications and insurance coverage. And this might be traditional therapy or psychiatric care, medication, or might be something like a self-guided online program. And then analysis comes in again, and that Quartet Health monitors care quality, which allows them to track patient progress over time. It's really important to ask whether or not patients are getting better on a given treatment, and if not, carefully monitoring this allows treatment to be adjusted quickly. So the fourth part of their model, which isn't data-driven but is super important, is just supporting patients along the way. So they work to ensure communication between referring providers and mental health providers, which is often completely lacking, and helps to ensure more holistic care. And then Quartet also offers care navigators to patients in need of some extra support. So this model is being picked up by insurance companies, which is really encouraging in that a data-driven approach to mental health care makes sense financially as well and is being adopted. So Quartet has shown that they can successfully identify patients who might have a mental health struggle following a difficult diagnosis or treatment. They have reduced emergency department visits and hospitalizations by 15 to 25% for some patients, and significantly more Quartet patients access mental health care and in less time than patients cared for in other models. So while still slow growing, there are some other exciting advancements that have been made in mental health data science beyond the 3 case studies that I just walked through. So there's been work done to use electronic health record data to predict suicide attempts and deaths in outpatient settings, very preliminary work thinking about finding biomarkers to help diagnose mental health problems and to assess treatments, ongoing clinical trials, which we probably will always need, as well as some time series analyses using individuals' data. In some instances, this is wearable devices that look at how behavior and/or mental health status are related to physiological measures. I was recently on a panel with someone who was telling us about the VA partnering with Fitbit to get physiological data, and ideally down the road, they would love to be able to intervene in real time with patients in mental or suicidal crisis, which would be really fantastic. So definitely are some exciting things just kind of beginning to happen in this field. So last, I just want to talk quickly about our work at the New York State Psychiatric Institute. So most of what we do is evaluating the National Suicide Prevention Lifeline, and we have this really great iterative relationship with them where every time they change a service or roll out a new training, we evaluate the impact on counselor behaviors or caller outcomes and such, and report these findings back. And then entirely separate from that, and most recently, we use Google Trends data to assess the impact of COVID-19 on suicidality and suicide risk factors in the early stages of the pandemic. And this study was published in PLOS One in July, and is a study that I'm going to walk through today. So first, I just want to talk about Google Trends as a data source because it is publicly available and there's so much that you can do with it, and it's really fun to play around with and it's just like a really great data source, especially if you're more new to data science. So this is their website, and here you can get data that is a large random sample of all Google searches that then gets rescaled from 0 to 100. So I also have a screen capture for that. So you can start out by just entering a query. So I'm just entering depression because that's one that we used in this study. So you get this interest over time map that you can just scroll over to see the rescaled numbers. And then you get interest by subregions. You can also just hover over that to interact with it and see differences by states. And then you can see related topics and related queries, which is actually very helpful, especially related queries if you're looking for other queries that might be searched to get at the same topic that you're really interested in looking at. So you can also just click here to just download this data as a CSV. So it's super easy to use, which is why I recommend it. There's also an R package called gtrends-R, which is what I typically use since we download data for so many queries at once, but no matter what, it's really easy to get this data. You can also compare queries. So here I'm just comparing anxiety. You can see that typically there are more searches for anxiety than for depression. You can now look at that geographically. I see that Wyoming is the only state with more searches for depression. And then you can hover to see how that varies more by different states. And then when you compare two queries, you also get those same two maps and related queries for each one individually. And then you can take this a bit further by applying filters. So here I'm going to do New York again. You can also filter by time range. So maybe I only want the last 30 days. There's also a really convenient custom date range option. And there are categories. Maybe I want to make sure I don't get economic depression searches. I want ones for health. And then you can do image search or things like that too, but web search is typically what I end up doing. So now we're seeing a different pattern. Now that it's New York, this one actually does give you a much more granular breakdown, which is great. And then again, we get those same breakdowns for anxiety and depression separately here. Oops. Let's see. Oh, it's going back to the, okay. There we go. So for our COVID study, we hypothesized that social distancing and lockdown measures might impact suicide risk factors, including financial difficulties, loneliness, anxiety, grief as more people pass away, and increased stress levels, particularly for essential workers, parents, and individuals in unsafe or abusive home situations. So in order to test this hypothesis, we assessed changes in Google search behavior. This data source made sense in the context of our study because there's previous research establishing associations between search behavior and suicidal behavior, and actually even some evidence of better accuracy in search data than self-reporting. And also, and really most important in this context, was just the availability of this data in the early stages of the pandemic. We ran these analyses in April, and there just wasn't mortality or healthcare usage data available at that point. And Google search data was immediately available and not dependent upon overburdened healthcare systems. And honestly, it's not really clear if we'll ever have really accurate representative healthcare usage data for suicidality in that time, just since so many people were either not able to access care or putting off accessing care out of fear of being exposed to COVID. So we assessed queries from 4 categories to assess the impact of COVID-19 on suicidality and suicide risk factors. So those categories were suicide-specific queries, such as kill myself and commit suicide, help-seeking queries, such as National Suicide Prevention Lifeline and National Suicide Hotline, general mental health queries like depression and panic attack, and queries representing financial difficulties, such as unemployment and I lost my job. And then we also had the uncategorized query of loneliness, which didn't seem to fit anywhere truly properly, but still felt very important to assess. So our analysis followed a method used by Ayers et al. In 2017 to assess the impact of the 13 Reasons Why Netflix show on suicide rates. So for each of our search queries, we looked at weekly search data from March 1st, 2020 through April 18th, 2020, which we defined as the early pandemic period. We knew that the virus was circulating before March, but we didn't think that it would have had an impact on mental health before the first US death and when quarantines really started to go into place. So we used autoregressive integrated moving average, or ARIMA models, which were trained on 1 year of data. And we use these models to predict weekly relative search volume during the early pandemic period. So basically forecasting what we thought search volume would have looked like for each query if the pandemic had never happened. We then calculated the percent difference between these observed and expected values to see how the pandemic changed search behavior. So here are these percent differences between observed and predicted data with 95% confidence intervals. And you can see all of our queries in this chart here. As you can see, queries representing financial difficulty and the disaster distress helpline, which was extensively promoted during the beginning of the pandemic, are drastically elevated. And for the financial difficulty ones, this is a particularly concerning finding, as one study found laid off, which we have here as well, to be the greatest indicator among several queries of actual suicides with a 2-month delay. So this slide zooms in on those queries which were dwarfed by the financial ones. So it's the same queries that were on the last slide, but now, which were too tiny to see, so it's all these ones here. And so now that these percent changes are more visible, we can see that searches related to suicide actually moderately decreased. And our team attributed this pattern to the national sense of community in the early stages of the pandemic, that we're all in this together sense. And there is precedent for this pattern, such as the decrease in suicidality immediately after national disasters like 9/11 or the SARS outbreak. So based on this analysis, we expected a short-term decrease in suicide as people deal with the immediate stress and seek help, but then the possibility for a long-term increase, as we observed with the 1918 flu and 2003 SARS outbreak, if interventions are not made. On the bright side, as of the time of this talk, we've seen serious increases in suicidality, but none in actual suicide in the US. I know that there's been a lot published recently about Japan and that it's seeing its numbers go up drastically. That's not necessarily translatable to the US, and we're obviously certainly hoping that it's not. So there are several limitations to this study. So first, not everyone makes Google searches, and people without access to a computer or who don't search on Google won't be represented. Also, we base what we did off of relationships between searches and suicide deaths that had been found in the literature, but we had no actual mortality data to compare findings to at this point. Additionally, it's unclear how the pandemic may have impacted search behavior. And finally, it's possible that searching on Google might actually have a mediating effect. So when you search for something that indicates that you might be suicidal, such as how to kill myself or something like that, contact information for the National Suicide Prevention Lifeline pops up. And the hope of that is that someone who is suicidal and makes searches that indicate that might see that information and reach out for help, which if it's happening is obviously really great, but does complicate the relationship between suicide-related searches and then suicide deaths. So I just want to end by reiterating the points that I was really trying to make in this talk. First, that the mental health field stands to benefit enormously from data science. Second, that data science and mental health is lagging behind other healthcare fields, which have seen much more rapid growth and advancement. But third, that exciting advancements have been made that are encouraging and provide a starting place for additional work that is hopefully yet to come. So my contact information is here. Please feel free to reach out. And I'm happy to answer any questions that anyone might have at this point. Look in the Q&A to see. Okay, so there's one question about, I think, what software we usually use. So typically we're doing most of what we do in R. We do use SAS occasionally, which we're definitely starting to phase more into R, but typically everything that we're doing is based in R. And there's a question here. You touched on privacy issues, but it seems that this will be a big hurdle. Are there concerns of people being less willing to use certain devices because they know their data will be shared? What about issues of informed consent with their data from devices being used to find these patterns? How might this impact the accuracy / usefulness of big data and mental health? So that's definitely a really big problem and something that's going to be really hard to overcome. I think that kind of goes back to what I was saying before of issues that are really difficult, but not necessarily insurmountable. I do definitely think that there will be some issues of people being less willing to share information if I know that that might be used for research. In terms of informed consent, everything that we do goes through our institutional review board. So anytime that we're using data that is at all connected to an individual, that has to get reviewed ethically, and the people whose data are being used have to know what we're using it for and consent to that. So in instances where we're using data connected to an individual, we definitely are always getting informed consent, and that's the challenge that we have to overcome. For some data that is completely anonymized, like the Google search data where nobody is publishing who is making these searches, and that's not something that you can get as a researcher, when you go on the Google Trends website, it's just a rescale number of searches. No one knows who's making that. So that's one of the reasons that we like using it, because people we think might be more honest, since that can't be tied back to them. But it definitely is something that we have to think about in terms of, as you're saying, accuracy of the data. What I was saying with people, social desirability bias, people not being willing to admit that they have these symptoms or have these diagnoses. So it's definitely something that I think we have to keep in mind moving forward, but not something that I think is going to prevent us from being able to make progress in this area. And then someone's asking if I will be able to share the slides. I definitely can. I'm not sure how that's usually done, but I can put them on GitHub or something, or I'm not sure if Magnimind emails them out. But I will make sure that is done. Then do you consider regression analysis to predict suicide? So we do use regression analysis for a lot of our analyses. For this particular COVID one, we are more trying to get at the scale of the changes in search behavior, which is why we ended up doing these ARIMA models and seeing what we would have expected without the pandemic and looking at that percent difference. But we do use regression for a lot of our analyses. A lot of times it's more looking at using the regression to get those beta estimates to see how certain predictors are tied in. So for certain analyses, yes, and different kinds of regression analyses, but for this one, it just wasn't what made the most sense. So, and there's one, what is the percentage of student suicide rate as against the overall suicide metric? So I don't have the exact numbers on the top of my head. I know that it is higher among students. It's also, it's very high among younger age groups, which tends to be students in general. And then I do believe that within that, it's also higher among students, but I'd have to get back with you with the actual percentage. And someone's asking if there's a specific group of people associated with use of the crisis text line. So I know that it tends to scale a bit younger in terms of people who are reaching out to a text line or to a phone hotline. Typically, you see younger people reaching out to a text line and older people reaching out to a phone line. Although that's obviously not completely accurate, but in their blog, they share a lot about the breakdown of who's reaching out to them. And I know that's changed with COVID as well. So in terms of an actual breakdown, looking into their blog is definitely a great place to get more information about how that's changing over time. And then, so someone's asking, do I happen to know the data source for crisistrends.com? So that's data that they have internally from conversations that they're having. So whenever they have these text conversations, all of that text data is kept by them. And they have a team of data scientists internally who's both publishing their blog with insights from that data, and then also creating the dashboard based off of those data. So since they are their own internal data and connected to individuals and so personal, that data isn't publicly available, but I still find the dashboard useful just for looking through and getting different insights about how things vary geographically and temporally in the US. Okay, and then someone is asking, saying curious about the ethics behind insurance companies using MLPI to predict who is prone to mental health issues. It would logically affect these individuals' premiums and maybe even push someone who is prone to depression, anxiety into them. Thoughts? So I think for the first part of what you're saying about premiums, that definitely is a really complicated area. Since I'm in the public health side, we always tend to think more just about finding people who need care and getting them into care. And that ends up being the main priority. But I do think that what you're saying about the potential for premiums being impacted is definitely valid. I think that kind of goes into a larger question of how our healthcare system works and the fact that having a mental health issue is not just an issue for you personally to deal with, but then also something that affects what you have to pay for healthcare and access to that. So I'm not aware at the moment of particular instances where an individual has been identified through one of these algorithms, and then that gets communicated in any way to insurance companies. But I do think that that's something that's certainly important to keep in mind as these algorithms are developed. And hopefully there is a way to use them in a way where we can find people and get them care, but not jeopardize people who may not have those issues, or who do, not forcing them to pay more for insurance. I don't think the other part of what you're saying about pushing them into depression and anxiety, I don't think that there's evidence of having those kinds of conversations or that kind of indication that you might be more prone to them, and then having that be kind of the impetus for you developing those issues. I know personally, focusing on suicide, the research that I'm most deeply aware of is research about whether or not asking individuals about suicide can kind of put thoughts of suicide into their mind and make them suicidal. And that's largely been debunked. I'm not as confident if that's true for depression and anxiety, but my gut is that it probably is. Okay, and there's another question of, would you be open to telling us how you'll navigate your career from here on out, and what are future opportunities? I'm looking to get into the industry and would love to hear your experience. Yeah, so I am currently on the more academic government side, working at the Psychiatric Institute. I ended up there I went to Columbia for my graduate program, and they're connected to the Psychiatric Institute, and I was working there when I was in school and now after. In order to advance your career in the more government side, you really have to get your PhD and then become a principal investigator, which is not something that I personally at this point think that I'm interested in doing. But there are lots of really great mental health tech companies, both in New York and throughout the country and worldwide, that I think are going to be more of my next step, where I can use the skills that I have and then can work my way up the ranks without having to get education beyond my current master's. So a few of the companies that I mentioned here are companies like that. There are ones that are focusing more on those wearable devices, ones that are focused much more just on kind of creating those algorithms that look at healthcare records and things like that, ones that are much more on the healthcare side and actually working with providers. So I would say for me, at least, it's going to be figuring out what kind of company I want to be at, but definitely something in the mental health tech world that is outside of government and academia. So there's a good question that I'm not quite sure how to answer of, how can designers and software developers support these initiatives? Are there particular companies or groups that we can get in touch with? I have to think about that, but my gut instinct, I guess, is that I know that on the academic side, where a lot of this work is happening, there tend to be pretty tight budgetary restrictions. And I know that partnership on a kind of volunteer basis between tech companies and academics can go very far. So something like that might be most useful. I'm not quite sure if that's what you're asking, but I wish I had a better answer for that one. But okay, someone's saying, as someone who has background in machine learning and data science, but not mental health, how can one transition into this field? So I have to say that's definitely the better position to be in than the opposite. A lot of that substantive model or substantive information you get more on the job, and a lot of that were things that I got outside of my coursework and professional work for a while. So the biggest things I would say you could start doing is really diving into the literature on these. There are a lot of great publications that are coming out. There's so many that I don't even have one particular one to recommend, because it really would kind of depend where in mental health you were interested. But I would say, if you go on LinkedIn and follow some of these mental health tech companies, they post a lot. You can get a sense of the kind of work that's being done. And then if you're looking more in the literature, you can get a sense of kind of where the field is at in general. But I definitely think it's easier to kind of build the mental health knowledge and self-teach that than to self-teach the machine learning and data science side. So I definitely think that that's doable. It just kind of takes some time. Okay, and then someone's saying, how did you get involved in mental health? I'm trying to figure out which field to get involved in data science, and I have children with anxiety and depression, and you work in the Medicaid industry. So for me, I've just always really been passionate about mental health, and when I chose my graduate program, it was largely because the Psychiatric Institute was connected to Columbia, and so for me, it was something I was able to kind of get into through my graduate program, which I was lucky about. But since you're saying you have a very personal connection to it, I think the vast majority of people in this field do, and it's really great working on a team where everyone is really deeply connected to what we're doing. I think since you're in the Medicaid industry, since you already have that kind of healthcare experience, I definitely think you could probably make that transition. As I was saying before, I would try to look at some companies on LinkedIn and follow those, look at the literature. It's also definitely always worth just reaching out to people who are in the field and having those kind of informational interviews with them to get some more information and to start building a network in more mental health data science. So there's one question of, could you share more detail regarding how to approach a question like who is experiencing mental health issues? So that was what I was talking about with some of those algorithms that can look at healthcare data or like medical records to see if they can pull out people who are more likely to be at risk for a mental health issue. Also, the case study of Ellie, the 3D chatbot, is trying to address that question. Her whole like the goal of her whole creation really is asking people about PTSD symptoms and being able to use that AI to get more symptoms of PTSD identified than alternatively. There also has been, as I mentioned, some work looking at how you scroll through social media and things like that to see how basically like can look at how long you spend looking at pictures and things like that and how your scrolling patterns are. And that can be predictive of depression. So, and then also with wearable devices, like what with the VA was doing of trying to see how your heart rate and things like that changed and identifying if you might be having an anxiety attack or something like that. So there still is definitely, as my whole talk is trying to get at a lot more room for this to improve, and there is definitely not, we can't just completely diagnose mental illnesses based off of data science at this point, and the clinical side is still very important, but those are just some ways that that's starting to become a bigger part of the field. So one question of worsening systematic socionomic problems being the root cause of rising suicide rates. How can we use AI on those? So it's, addressing socioeconomic problems in general is definitely a really, really huge undertaking. I definitely think that AI has room to have a place in all of these. Personally, being in public health, most of the roles that I know for AI and things like that are very much on the academic research side, but there really is actually a huge and increasingly growing body of literature using machine learning and AI to at least evaluate these problems and then to evaluate some measures that are taken to address them. But I'm sure that there are much broader initiatives going on beyond that. They're just outside of what I'm aware of, but there, at the very least, is a lot going on academically with that. And someone's asking where there's more information on Ellie. I'm curious about the patient interactions that was presented as a chatbot, but it mentioned facial expressions and body language. Was this some natural language processing type of application or a combination of chat and image analysis? Yeah, so there are some actually really good YouTube videos of her in use. YouTube videos just don't really come through well on Zoom, so I didn't include any. But if you search her there, you can see her being used. So you're right, it's both the natural language processing, and then she's also looking at the patients. There's some image analysis going on too, and then that speech analysis of things like how long you pause between your words and things like that. There are some academic publications on her use, and there are several more like newspaper articles that were written interviewing her creators. So if you just do a Google search, I'm sure you'll find a lot of that, but I definitely highly recommend the YouTube videos as well. So one question of why a REMA model was used. So I touched briefly on that. There are multiple different ways that you can approach this kind of problem. Typically, we end up doing more of a change point analysis with data like these. So looking at if there was a sustained change in a pattern after a certain point. But we were looking at this question and really realizing that we knew that there was going to be some sort of change for most of these, and just pointing out that searches related to financial difficulty increased didn't feel that meaningful. And so even though the vast majority of the time we don't use percent change because it's not as statistically valid as other things, In this instance, and also since we were just trying to publish quickly and we're very familiar with these models, because we really wanted to draw attention to this issue at the very beginning of the pandemic, we wanted to use the UREMA model so that we could really point out how stark these percent differences were, and having ones in the thousands really stood out to us. And also, as I mentioned, since it was a technique that was used previously to assess something else that was similar and used a lot of these same queries, just having that precedent was something that was important to us as well. But yeah, there's other people are commenting about other things that we potentially could have used, and it's definitely an instance where there are a lot of different approaches to this. And as I said, a lot of it too is really just, we knew this was a huge problem at the early stages of the pandemic. We saw everyone obviously, like very validly, being very concerned about the pandemic purely in terms of the infectious disease side, but we also knew there was going to be such a huge mental health side. We saw it with so many other pandemics. It wasn't something that we were really hearing about, and we really just wanted to do something that would show this was happening and get it published, that we could hopefully get attention to that. There definitely are other techniques that, if we have more time with it, may have been better to use. So one person's asking, do you happen to know of any studies that utilize data science to predict what could reduce racial disparities in accessing care? I don't have any specific studies off the top of my head, but I know that this is a huge area of research. There's also been a lot written about a lot of the data that's being used in a lot of healthcare data science and AI machine learning work, and the fact that a lot of that has built in issues where either it only represents primarily light-skinned people, or it tends to bias to have higher premiums for people of color. But like, there's a lot, people are becoming much more aware of issues around that. And then I know that there have been a lot of studies that look at specific initiatives trying to reduce racial disparities. Again, I don't have specific titles off the top of my head, but if you're able to find a journal database and look through that, there absolutely is a lot of research in that topic. And from so many angles looking at it too, which obviously is very important. And then another question of if R is generally used in mental health data science, or if it depends on the institution. So R is definitely very, very widely used. I'm not sure if it's, I mean, I know that there are some institutions that are more Python focused. I think there's been a lot of job descriptions I've seen that say either R or Python, and it kind of ends up being whatever the individual prefers. At my institution, it's R or SAS, which is not really used anywhere outside of government and academia in terms of healthcare. But I would say if you know R, you're going to be mostly set for this. But it is something that's worth looking at that specific company if you're interested in one, and their job descriptions to see if they are one that's more geared towards Python. Okay. And then one person's asking if I discussed EEG data. So unfortunately, that's not something that I really have used that much, since we're mostly focused on hotline evaluation. I'm not really on the clinical side with it. So I know that there is work that does use those. And I know that there is some predictive validity to that data, but I don't know enough to speak really in depth about how good it is as a data source. So someone's asking, how do you get demographic data, age, gender, ethnicity, education, paired to the data to gain deeper insight into population clusters? So that's a really good question. It depends a lot on the kind of research that we're doing. In terms of the Google searches, that was something that we were upset that we couldn't really get, because Google doesn't give anything identifying with that kind of data. But so with one of the studies that we're working on right now, we're looking at people who called the Lifeline. That's something that we just directly ask. And so we are able to see if people of certain age groups, genders, ethnicities, whatnot, have a better experience, or if that treatment is more geared towards them. It really depends a lot on the data source. If you're using something like more clinical data, on the bright side, that usually tends to all be there. But it's something that's just very data source specific, but very important to look at, as you're mentioning. Okay, and then could you provide an example regarding how and what data can be used to verify the result / accuracy from a predictive model established in this field. One would be what we're hoping to do at some point of looking at what we're looking at with Google searches and looking in suicide long-term. So we're planning to redo that study, looking at the pandemic more long-term. And then once we have mortality data for suicide-related mortalities, and then also hospital admissions for suicide-related crises, and then potentially also outpatient mental health services, we can see if what we predicted suicidality to be was actually validated by looking at suicidal behavior. So that's just one example. And I think that is all of the questions. Oh, no, there's another one below that. Okay. Do you know what timeframes are used or how they are defined to determine treatment success? That's definitely one that varies treatment to treatment. So a lot of mental health things just take longer to work, and especially for things like medications, it can take a while for you to see if you really are experiencing an improvement. If you're seeing a therapist once every 2 weeks, that's going to take a while to have an impact as well. And so for us, since we're again looking mostly at timeframes, that tends to actually be a shorter one if we want to see how that person is feeling immediately after their call, and then potentially a few weeks after their call. And then the longest we've really looked out is 6 months or so. So that one's definitely shorter because it's such a directed intervention. But then I'm not sure the exact like month or year markers that are used, but for things like therapies and medications, it definitely is a longer time period that you have to look at to see if that really works for somebody. So now I think that is all of the questions. Okay. Yeah, and if anyone else has questions later on, I moved off that slide somehow. My contact information is here. So please feel free to reach out to me if if you think of questions down the road.
Thanks all attendees, and Emily, thank you for your presentation.
Thank you for having me. Okay, I can stop share.